Good morning, everyone. Assalamualaikum and good morning to all. Welcome to Breakfast at UMHealth. My name is Adina from the Department of Primary Care Medicine, and I am here to introduce the first speaker for this morning session, which is Dr. Rizawati Ramli. Dr. Rizawati is a new lecturer in our department. She received her MBBS from in 2003 and her master's in family medicine, also from in 2012. After her graduation, Riza worked in Sabah for 3 years, then came back to Klang Valley to serve as a family medicine specialist at Klinik Kesihatan Bukit Kuda. While she was there, she was involved in the Respire project led by Professor Ku Yiming in 2019. Her talk today is the sharing of her research done under this project. So Riza, without further ado, please can I ask you to welcome Dr. Rizawati to deliver her talk, Asthma Care for Hajj Pilgrim. Riza, the platform is yours.
Okay. Assalamualaikum to everyone. Thank you to Prof. Adina for the introduction. So, as introduced by Prof. Adina, I'm new lecturer. So, thank you to Committee of Breakfast at UMHealth for the opportunity for me to talk about Malaysian Asthma Hajj study, which is one of the research projects of Respire. Allow me to share my slide first. Okay, so I would like to start off by explaining briefly about what Respire is. Respire is a global health research unit on respiratory at the University of Edinburgh. That is funded by NIHR. So their projects involve lower and middle income countries, and besides Malaysia, India, Bangladesh and Pakistan are also involved. The principal investigator for all projects of Respire in Malaysia is Honorary Professor Ku Yiming, and besides University Malaya, University Putra Malaysia also is involved. So all Respire projects in Malaysia focus on chronic respiratory disorders, namely COPD and asthma. So today I'll be talking about one of the asthma projects, which is Malaysian Asthma Hajj study. So for your information, the site principal investigator for this Hajj study is Prof. Liu Sume. So the study was conducted in 2019 before the COVID pandemic started. After which, for 2 years, there was no Hajj for Malaysian, including this year. So next, I would like to briefly explain on what Hajj is, especially for those who are unfamiliar with Hajj and the non-Muslims, so that you can relate how the Hajj heightened the asthma risk and appreciate the importance of this study. But mind you, this study was not conducted in Saudi, but in Malaysia. So Hajj is among the largest human gathering. 2 to 3 million people from more than 140 countries perform Hajj every year. So Hajj is an obligatory religious duty for all adult Muslims who are physically and financially capable, at least once in their lifetime. In Malaysia, every year there is about 30,000 of pilgrims perform the Hajj, of whom a substantial number of them are elders and infirm. So Lembaga Tabung Haji is the key institution that provides various facilities for Malaysian Hajj pilgrims. Besides crowdedness, the geographical and environmental factors also increase the health risk, including for asthma. The city of Mecca, the main city where all the worships activity happen, and its surrounding region, where located in the desert. So it is dry, dusty and hot. The temperatures are high throughout the year. It can go up to 40 degrees, even though there are some colder seasons where the night temperature can go between 18 to 19 degrees. Okay, next I will run you through the Hajj activities itself. So this picture is to illustrate the movement of all pilgrims as they go along performing all the rites of Hajj, which are performed over 5 to 6 days. So it is around the time when Muslims celebrate Hari Raya Haji in Malaysia. So the rites are very physically challenging. even to younger people, let alone the elders. So in the city of Mecca itself, where the main mosque, we call it Masjid Al-Haram located, pilgrims will perform two rites, which are Tawaf and Sa'i. Okay. So Tawaf, the top left box, is when they circumambulate the Kaabah. So depending on the position from the Kaabah, which is located right in the center, the distance is between 500 to 1 kilometer for 7 rounds. Okay. So next is Sa'i, the box right on the right side. For Sa'i, pilgrims walk or run back and forth between two hills for 7 times, and the distance is about 5 kilometer. And for all pilgrims, Tawaf and Sa'i must be performed at least twice. So from Mecca, they will move to Arafah for 1 day. So Arafah rituals end at sunset, and pilgrims then move to Muzdalifah for a short rest. From Muzdalifah, they will move to Mina. So, so in Mina, pilgrims will stay in a small and confined tents for about 2 to 4 days. So from their tents, if you can see all the pilgrims walking right here, they got to walk to Jamarat for stoning rituals for 2 to 4 times. So the distance from Malaysian tents to Jamarat and Jamarat back to the tents is between 7 to 10 kilometers. Then pilgrims will return back to Mecca. So all the 2 to 3 million pilgrims will go through all these movements and perform the rituals within the same period of 5 to 6 days. So Hajj is indeed a physically challenging activity. So asthma. Asthma is among the top causes of hospitalization and unscheduled medical attendances due to acute exacerbation and its complications. So given the extensive health risk posed by asthma during Hajj, the crowding, environmental factors, intense physical activities, and also mental stress. So the effort to optimize the health status of all pilgrims with asthma is therefore crucial. So it is mandatory for all prospective pilgrims to undertake health examination and certified fit for Hajj. We don't have our own local data, but in neighboring country Indonesia, despite the compulsory health examination, 47% of partly controlled and 61% of uncontrolled asthma at embarkation for Hajj, they had exacerbations during Hajj. So we aim to explore the feasibility and acceptability of a potential intervention based on the current routine of pre-Hajj medical checks or medical examination and the perceptions of stakeholders involved. Of course, the ultimate aim is certainly to reduce the risk of performing the Hajj for people with asthma. But besides asthma, it could also be extended to other chronic respiratory disorders like COPD. So asthma can be used as an exemplar of chronic disease to influence future strategies to improve care among pilgrims. So this is briefly the design of our study. We conducted observation at 12 clinic kesihatan and 2 general practitioner clinics to obtain ethnographic understanding of the clinical routines of Hajj health examination. We interviewed stakeholders involved with Hajj health examination, who consist of personnel from Lembaga Tabung Haji, Ministry of Health, and doctors. We administered questionnaire and interviewed a cohort of pilgrims before Hajj and after they have returned back to Malaysia, and we also obtained a few data from Lembaga Tabung Haji. So this is the process of Hajj Health certification in 2019. So prospective pilgrims received their offer letter somewhere in February to March. It was between 6 to 7 months before Hajj. After which they had to attend preparation courses. So one of the courses was in health aspect, but it was much on general healthcare. So around this time also, around February, March, the training for doctors, including medical officers and family medicine specialists and general practitioners, were organized across the country. So all these doctors would get their Hajj certification number to enable them to perform the health examination and issue the Hajj certification. The pilgrims then went through the Hajj examination process. So the Hajj examination activities were conducted at all districts through 3 to 4 months. Districts with bigger number of pilgrims mostly conducted it in at a centralized clinic, whereby one clinic was selected and all pilgrims from the same district attended this selected clinic on a scheduled day. So for the 12 clinic kesihatan that we went, the total number of pilgrims who attended the Hajj examination per day ranged between 7 to 324. And pilgrims who were certified fit for Hajj would then proceed to receive their meningococcal vaccine, which was given for free, whereas those who were not would be referred for further assessment and re-evaluated later. So in the end, a total of 33,076 Malaysian flew to Saudi to perform Hajj in 2019. So let's have a look at the findings of our study. So I would like to start off by showing you some important quantitative data. So we assess the level of asthma control using GINA recommendation on a cohort of 105 pilgrims with asthma before they embark for Hajj. GINA, for those who do not know what GINA is Global Initiative National Asthma. It's actually asthma guideline of which the recommendations are widely used by asthma care providers. So from this questionnaire, we found that 1/3 or 31.4% of the cohorts did not have a good asthma control. There was a study conducted at 14 clinic kesihatan in 2017 which found that only 41% of all asthma patients had good control. It was also concerning to learn that more than 2/3 or 72.7% of the pilgrims with uncontrolled asthma perceive that their asthma control as good. So this mismatch between patients' perception and objective assessment is consistent with previous two studies which reported a very high mismatch, which was 72% and also 89% respectively. So here we can see that there is a need to improve the provision of asthma education to patients on how asthma control should be determined, which is one of the important components of asthma action plan. Okay, so among this cohort, more than 10% still had exacerbations within 1 month, which indicate poor control status just prior to their Hajj, and 6.7% had history of admission due to asthma in the last 1 year. About 5% had life-threatening asthma requiring assisted ventilation, indicating that small number of them had high asthma mortality risk. I would like to draw your attention to 4 crucial aspects of asthma care, namely the controller use, asthma inhaler check, asthma action plan, and regular follow-up. More than half or 60% of the cohort was not using controller. Very high proportion of them did not have the inhaler technique checked, which is more than 80%, and asthma action plan being provided and explained to them, which is more than 90%. More than half of the cohort did not have regular follow-up for their asthma, and only small proportion of the cohort received influenza and pneumococcal vaccines, which were actually optional and not provided for free. Okay, the next table is few data obtained from Lembaga Tabung Haji on the health service utilisation among Malaysian pilgrims during Hajj in 2019. So the total outpatient visits were double the number of total pilgrims. So roughly, in average, each pilgrim required outpatient care of about 2 to 3 times. More than half of these pilgrims, or more than half of outpatient attendances, was due to respiratory causes, with substantial number of them were URTI. And of this total number of respiratory illnesses, 1.6% were recorded as asthma exacerbation. The total number of admission was 3%, with nearly half of them was due to respiratory causes. 24 total deaths occurred, where again almost half of the deaths were due to respiratory causes, but no asthma death was reported. So we followed up this cohort after they have returned back to Malaysia. So one of the pilgrims in the cohort passed away during pilgrimage. In the end, we managed to get response from 90 pilgrims from the 105 pilgrims before Hajj. So we reassessed their level of asthma control using GINA, and we found that the proportion of pilgrims with poorly controlled asthma doubled the number of before Hajj, from 31.4% to 64.4%. Okay, so 1/3 of them had episode of exacerbation, 32.2%, and small number being admitted, but no pilgrim required assisted ventilation. We also interviewed a sub-cohort of 13 pilgrims who had exacerbations during Hajj. These were some of the triggers for their exacerbations: the hot climate, dust, prolonged cough, crowding, and physical exertions. It is important to know this information so that we could appreciate what are the real triggers over there, and include that in asthma education on the preventive measures. These are few more triggers, like small and confined tents, long distance between hotel and the mosque, and again the hot climate. Well, these were some steps taken by the pilgrims when they had the asthma symptoms, in which some of them are quite concerning because many of them actually did not practice specific asthma action when they had the symptoms. We can see from here none actually reported that they quickly took their reliever. Okay, some other measures were like just drinking holy water and pray to God. Okay, so we have known some estimates of several important indicators of asthma control among the pilgrims, and some real experiences of how they manage their asthma during Hajj. So now I want to bring you backward to see what we observe from the Hajj health examination itself. So all in all, the asthma care was found to be suboptimal. There were several contributing factors that we see have potential rooms for improvement. Time constraint for adequate clinical assessment and inadequate resources were some of the factors. But besides the organization of the health examination itself, the provision of asthma care and the provision of asthma care by primary healthcare providers warrants some form of evaluation and improvement too. So the asthma care was found to be suboptimal among medical officers. We observed variation in the adherence to guideline recommendations, whereby the assessment of control, medication adherence, and inhaler technique check, including the need for spacer, were found to be suboptimal. I could not find a local study which explored on asthma guideline uptake and adherence among primary care doctors, but there was a survey conducted in 2012 in the US, which found the adherence to recommendation of asthma action plan and inhaler technique check was very low, of less than 20% among primary healthcare providers. The PFR reading did not seem to influence the doctor's management, even if it was done. We also observe hesitation on the management and certification for pilgrims with uncontrolled asthma. The medical officers typically referred the cases to family medicine specialists for further management and finalize the fitness certification rather than optimizing the asthma treatment themselves. And we also observed little or no individualized asthma education on preventive measures or provision of asthma action plans was provided to the pilgrims. So we seek to understand what are the barriers and potential enablers or facilitators to asthma care from the relevant stakeholders. And these are some barriers perceived by the doctors. So the low literacy, especially older pilgrims, hinder the delivery of asthma education. Treatment intensification could not be provided due to limited long-acting beta agonists like Saritide and Symbicort at the clinic kesihatan. In terms of organisation, the time constraint to perform adequate clinical assessment had posed pressure to the doctors, and therefore the Hajj health examination was viewed mainly as ticket for certification for Hajj instead of the opportunity for them to optimize the chronic disease for long-term benefit of patients. Some measures were perceived to potentially facilitate the asthma care according to the respondents. Certainly, the longer time frame for the certification process would provide more ample time for disease control. Others are like education supporting materials to accommodate the low literacy pilgrims, provision of care by dedicated asthma team, and some measures to improve clinical competency of primary healthcare doctors, like in the form of case audit or training. By and large, there is great potential to reform the Hajj health certification in Malaysia and to improve the provision of asthma care in primary healthcare. Approach to restructuring the delivery of Hajj health examination could address the time constraint, the clinical competency of primary healthcare providers or doctors, and resources limitation like medicines and vaccines. This is to reduce the risk posed from asthma and by extension the other chronic diseases too, not only during pilgrimage but also the impact on long-term health. These are my references. With that, I thank you.
Thank you. Thank you very much, Riza, for that wonderful talk. And a great revision on what Hajj is as well. So that was quite good. There are some questions in the Q&A section. I'll read that for you. Okay. Firstly, Prof. Chan asks, are those doctors in the clinic that do the evaluation for the pre-Hajj certification, are they trained to correctly determine good asthma control?
Okay. So again, so specifically for Hajj examination, they were required to attend Hajj course, whereby during that Hajj course there are modules that actually guided them on how to perform and how to evaluate and do the certification. But the rest of it is back to how the provision of care by primary healthcare providers. So training of asthma is I would say is quite adequate when I was working at KK, but we never had like a really and good audit to see whether our doctors, especially medical officers, doing the evaluation for asthma control, appropriate management of asthma, whether it's actually happening or not. We do have audit, but it's just a simple audit which we conduct annually at KK.
Okay, but I think I echo your answer in that they should be trained already because they are doctors working in KK, and they are
Mm,
taking care of asthma patient during their normal
mm.
working hours, not just for the pre-Hajj screening, right, Dr. Riza?
That's right.
Yeah, is
That's
right.
right.
Okay. I think Prof. Tunku Sarah said, fantastic research, a great screening test to improve asthma care in general before and after Hajj. So so what's your response to that?
Okay, so maybe I just tell what is our current stage. So we are in the process of disseminating the findings, and hopefully we will be able to meet Lembaga Tabung Haji and Ministry of Health to share our findings, and so that improvement measures can be planned and hopefully implemented in the future for the sake of not only our Hajj pilgrims but also for long-term benefit of our asthma patients.
Prof. Chan has another question. Do you think the high regard for dying in Mecca influenced the pilgrims in not optimizing their respiratory care? I like this question actually.
Can you rephrase the? Can you ask repeat the question, Prof?
Okay, so do you think it's because they want to die in Mecca? You know, they got
Oh,
this
okay.
feeling like I want to go there and die there, so they don't really care about their disease, be it asthma or diabetes or heart disease, because their aim is to pass away in Mecca because of the high regard that they have about dying there. Do you
Yeah,
find
I
that?
think
Do you
some.
find that in your interview?
Oh yes, not during interview, but
Uh,
because I had experience working in KK before this, whereby I involved in Hajj examination. So especially for those with uncontrolled whatever medical problem is, diabetes or asthma, when we tell them, okay, I cannot pass you today. You need further assessment, or in the end, you cannot go. It's something require like a good communication skill for us who to inform them, you know. So yeah, they would say it's a holy land, so I would want to die over there. It's okay, but they don't understand the implication over there, you know. From okay, for your information, I also had experience working as medical team in Saudi. So some of the patients who finally passed and went to perform pilgrimage, some of them actually right after they land, you know, maybe for the rest of their life they never like get on a plane, so and long journey. So right after they landed, they already fell sick. So it's difficult to communicate and to inform them, because they have a fixed mind. Okay, I go to Holy Land, I want to, you know, like it's okay for me to die there. Yeah, it's about communication.
yeah. And I think Sume, which is one of your investigator as well, right? Your co-investigators from Sume mentioned that there are cultural influences on pilgrims' health behavior. During interview, they did say they did not have to take medications because their health will be taken care of by God, maybe when
God,
they're doing, yeah, because when they're doing Hajj, yeah, I think. All
just
right.
pray, just drink Zam water, just take madu, you know, things like that.
But I think it's interesting that do you interview them when they come back?
Yeah.
So do they have any do they reflect on their experience and say, oh, I should have taken care of my health better before or during Hajj so that I can have better experience, you know? Did they say something like that?
Perhaps I can share one response from one of the cohorts.
Mm,
She said, okay, she had severe exacerbation over there,
mm,
and she was suggesting first her perception was that why asthma was taken lightly. She
mm,
said patients with asthma should be given a hotel which is nearer to
mm.
the mosque, and then should be taken care well. So it's things like that, you know.
Okay, we're coming to the end. I can see the next speaker here already, but I just want to ask the last question by Prof. Tengku. Could this be extended to screen other diseases? And what do you think would be, because you say asthma is just an exemplar, so what would be your idea about the next disease to tackle?
Okay, basically when we do the pre-Hajj health examination is for all, is to address all diseases, not only asthma. So the findings from mainly the observation during Hajj examination activity itself, we can actually apply it to improve the care for other chronic diseases.
All right. Thank you very much. I'll hand it to Dr. Wan Ling to continue for the next speaker. Thank you. Thanks, Riza.
Thanks.
Thank you, Prof. Adina. Good morning and salam sejahtera, everyone. So my name is Wan Ling. I have the greatest pleasure to introduce the next speaker, who is my colleague, Madam Nur Aziyan Yahaya from Department of Nursing Science. Madam Nur Aziyan Yahaya will soon be obtaining her Doctors of Philosophy, and today she will be sharing her PhD project on development of a self-care education interventional program and its effectiveness outcome among women with breast cancer undergoing chemotherapy. So we are from asthma care, we are coming to the oncology care. Yeah. So Madam Aziyan will bring her wealth of experience into her talk as she works in oncology unit for 5 years in 1990. She pursued her post-basic training and her master study field in oncology too. In fact, she has published paper from her recent work. So let's hear more about self-care from Madam Nur Aziyan. So over to you, Yan. Thank you.
Bismillahirrahmanirrahim. Thank you, Madam Chairperson, Dr. Wan Ling, for the kind of introduction. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to the audience. So thank you to the organizer for inviting me to present and sharing my PhD study with the title of Development of Self-Care Education Intervention Program and its Effectiveness Outcome Among Women with Breast Cancer Undergoing Chemotherapy. So my content outline for this study will cover on the problem statement, the research objective, methodology, findings, and discussion, and also recommendation. Globally, cancer is one of the major causes of mortality and morbidity worldwide, and it is predicted to have an increases in the rate of incidence. Hence, the disease will be a major concern for many nations, especially poor or developing countries, where the rate of common cancers such as breast cancer is set to almost double in the near future. So, according to the data derived from Globocon 2018, a total of 106,262 new cancer cases were diagnosed in Malaysia at 2018, which increased 5 times from 2003. And although the number of new cases in Malaysia has increased, the survival rate of cancer is also increasing. And this make the challenges to healthcare providers to provide quality of care and meet the educational and care needs of patients within the fluid environment of ambulatory care and home setting. And as the requirement by the Malaysian Society for Quality in Health, healthcare providers must ensure to provide a quality of care and enhance patient safety. So a study conducted in Malaysia among various cancer patients undergoing active treatment found that symptom prevalence was relatively high and ranged from 14.9% to 88.1%. And meanwhile, more than 60% of patients reported to have physical symptoms such as lack of energy, dry mouth, hair loss, drowsiness, and loss of appetite. And this require the healthcare providers to prevent, addressing, and relieving the symptoms and side effects experienced by patients due to their condition and treatment. So for the problem statement, the researcher was interested to do this study because of the following reason. The first reason is the gap in evidence of cancer symptom management study in worldwide is inconsistent. And the recent literature review in Western country on various nursing interventions, including coaching, telephone follow-up, and home care has been reported, but the results on relieving symptom burden, quality of life, and psychological distress has been inconsistent. And the second reason is the lack of study in Malaysia. So there is a limited study done in Malaysia examining the symptom and self-care management among cancer patients receive cancer treatment by nurses. And only 2 local studies recently found that through chemotherapy counseling intervention to cancer patients on side effects has positively improved self-esteem and psychological effects. However, the study did not measure patient symptom burden, activation level or self-efficacy during chemotherapy. And these outcomes are also important for measuring the effects of intervention during treatment. And since there is a lacking in self-care management research among women with breast cancer undergoing chemotherapy, so the researcher took an opportunity to overcome the gap by developing and testing the self-care education intervention program to improve cancer patient self-care management of symptom burden, quality of life, patient activation level, and reduce psychological distress. For the third reason is the need to focus on symptom cluster rather than single symptom. So literature demonstrated that the high prevalence of symptom cluster present a great challenge for the researcher that interested in conducting intervention study in this field due to the complexity of symptom cluster and insufficient understanding. So until today, the study on symptom clusters is still in its infancy stage with different understanding on the characteristic of symptom cluster. So thus, many studies found that there was a lack of clarity about the etiology and significance of symptom cluster, which means that the effectiveness of intervention were not well developed. So because of this limitation, the current intervention study is required to focus on the symptom cluster rather than the single symptom. So the fourth reason is the difference of socio-cultural context in assessing symptom cluster and symptom management. So as we know, Malaysia is a multiracial and multicultural country, which differs in the geographical environment, cultural practices, perception about the symptom experience, and self-care strategies in managing symptoms. Therefore, qualitative study is best to explore on patients' perception of symptom cluster experience and self-care practices among Malaysian patients as to develop the content for the intervention at phase 2. And the fifth reason is the researcher's observation. In Malaysia, there's currently no proper standard guideline or module for oncology nurse to counsel patient on the side effects of chemotherapy, symptom management, and monitoring patient side effect at home. So therefore, the oncology nurses educate the patient based on their prior knowledge and experience in helping patients to cope with and overcome any side effects of chemotherapy. And this might cause patient to have lack of confidence to perform self-care at home due to the inexperienced nurse who provided the education and later results in more psychological distress during treatment. So for the main research objective in this study is to develop and evaluate the effectiveness of self-care education intervention program in reducing psychological distress and improving patient treatment-related concern, quality of life, patient's activation level, and symptom burden among women with breast cancer undergoing chemotherapy. So to achieve the main research objective, few specific objectives were formulated based on 3 phases of the study. So for the phase 1, the qualitative research is performed. So the specific objective is to explore symptom cluster and self-care strategies by women with breast cancer undergoing chemotherapy. And for phase 2 is the development of intervention, and it is based on the intervention mapping approach by Bartholomew et al. 2011. And for phase 3, is to will be the main research objective, which comprise of 7 objectives that measures on the 7 variables of psychological distress, cancer treatment related concern, quality of life, patient's activation level, symptom burden, self-care strategies, and evaluating the feedback of the intervention program. So for the literature review, for quality of life, 6 review studies by Howard et al. 2017 found inconsistent finding in improving quality of life, and most of the study did only 1 point of time. And for psychological distress, 5 studies found anxiety has decreased, and only 1 study decreased over time. And in depression, out of 4 studies, only 2 showed depression decrease over time. So in providing information about the treatment of cancer shown to have reduced the anxiety, pain, and distress, as well as faster recovery with fewer complications. So for the activation level, most study found higher activation score are positively correlated with adherence to treatment and condition monitoring, and as well as obtaining regular care associated with the condition. However, Most study done with other chronic conditions such as diabetes, heart failure, and there were no studies yet doing on women with breast cancer undergoing chemotherapy. And for symptom burden, there were 11 review studies explored on the multifaceted symptom management by Coolbrand. And through the review found that some studies failed to show significant effects and only few reduced the aspect of symptom burden by 10 to 88%. And in self-care strategies, a descriptive study found that diet or nutrition, lifestyle changes, mind or body control, biologic treatment, herbal treatment, pharmacological intervention, and exercise were the most common self-care practices by cancer patients undergoing various cancer treatment. So the conceptual framework of this study was based on the revised of symptom management model by Dot et al. 2001, and the concept of symptom cluster by Miolkowski 2016. So the domain of symptom experience in the revised of symptom management model was replaced with the symptom cluster, which derived from the qualitative outcomes of the phase 1 study. Okay, under the research methodology, an exploratory sequential mixed method embedded design was used to achieve the objective of the studies. And this design is useful when a researcher need to embed a qualitative component before the quantitative design and to inform the development of a treatment. So in this study, qualitative approach was used and its data was included to develop content for education program and self-care diary as one of the tool in the intervention. And this study consists of 3 phases. So the first phase was a longitudinal qualitative approach using critical incident technique analysis by Flanagan 1954. And then phase 2 was a development of a self-care education intervention program using the intervention mapping approach by Bartholomew et al. 2011, which consisted of 6 steps. And phase 3 was the main study, which was a longitudinal, quasi-experimental, non-randomized pre- and post-tests with sequential design, which have 3 follow-ups. So this slide actually showing the outcome findings of phase 1 qualitative research, which the researcher had used the critical incident technique analysis to count the incident frequency. So counting the frequency was based on the category and subcategory emerged from the analysis. And for the first objective, 2 subcategories were emerged, which were the physical and psychological symptoms, and 200 critical incidents were counted. And across the 3 times point, there were 15 physical symptoms and 5 psychological symptoms were experienced by breast cancer women. And results of second objective showed that 5 subcategories were emerged, which counted 303 critical incidents. And the subcategories derived were diet, lifestyle changes, mind control practice, natural treatment, and pharmacological intervention. And it consisted of 97 self-care strategies. Okay, this slide actually showing the phase 2 development of self-care education intervention program, whereby the intervention was guided by the intervention mapping approach from Bartholomew et al. 2011, and it involves 6 steps. So the content of self-care education intervention program was developed based on the qualitative study approach and extensive literature review before the actual study, especially on the education content, booklet, and diary. And the content of the education booklet and diary was focused on the 20 physical and psychological symptoms that patient may experience during chemotherapy, and 93 self-care strategies that may help patients to manage the symptom at home. It is an individual tailoring intervention which consists of 2 sessions. So the first session of intervention is the face-to-face education session for 30 minutes, and another 30 minutes is about the briefing on the usage of WhatsApp group and diary. So the second session of the intervention is the WhatsApp chat group or personal, and we name it as a strong woman, which took about 10 to 15 minutes, whereby the researcher will send a short message every Monday and Thursday. So this may alert participants to join the chat if they want to ask anything about side effects and self-care. And also motivational interviewing is also included in the session, which the researcher used this method for coaching strategies during the 2 sessions and also throughout the treatment at around 18 to 20 weeks. So For phase 3 is a longitudinal quasi-experimental non-randomized pre and post test with sequential design with 3 follow-ups. And the study setting was at the Decade Oncology National Cancer Institute of Putrajaya. Prospective and consecutive sampling method was chosen for the study. Sampling size was calculated using G-power sample size calculation for repeated measure ANOVA, the within and between interaction. And sample size was calculated based on the effect size from previous study, for which alpha is 0.05 and the power of 0.95. So sample size was chosen according to the maximum number of sample size in each outcome. So however, 246 was successfully recruited in the study, and 30 women with breast cancer were involved in pilot study to test the comprehensiveness of the 4 instrument and the self-care diary to avoid any vagueness or ambiguity in the question asked. So Chromosome alpha values were calculated to assess the internal consistency and reliability of the questionnaire used. And the Chromosome alpha coefficient for all questionnaires was more than 0.6, suggesting acceptable internal consistency reliability for the scales. So for the inclusion criteria is the respondent must be at age 18 years old or older. They must not have any mental illness and cognitive impairment. The ECOG performance status must be at grade 1 to 2 and able to speak and write Malay or English language and must have good vision, and no restriction to medication or any procedure while on treatment. And for the exclusion criteria is that they should not have any experience of chemotherapy before, should not need any assistance with their daily activities and treatment therapy, had breast lymphedema, or was coached by any nurse navigator at the study setting, or were treated with the experimental therapy under clinical trial. So this slide is showing the flow diagram for phase 3. So data for actual study was collected from June 2017 until September 2018, started with control group until December 2017, and followed by intervention group from February 2018 to September 2018. And out of 264 eligible patients, only 252 give consent to join the study. And however, at cycle 4, 3 patients from both groups were dropped from the study due to distant metastasis and changed treatment to palliative chemo. And therefore, total patients for final were 246 until end of treatment, and the response rate was 97%. So actually, this is the findings of phase 3 quasi-experimental for demographic and medical characteristic. So tables show the comparison of group homogeneity in demographic and medical characteristic, and both were found to be similar characteristic because the p-value shows insignificant. So for the findings in research objective, my research objective number 1 on the effect of intervention in psychological distress. So a repeated measure Markova was applied to assess whether there were groups and time difference in patients' psychological distress. So in anxiety and depression level, there were no significant main effects for groups and time. However, the interaction between groups and time was found to be significant. This indicated that the changes of anxiety and depression level among patients in both groups were significantly different across the time. And the intervention found that there is a reduction of 31.8% of anxiety level in intervention group and 14.2% in control group at the end of treatment. And the difference of 17.6% reduction of anxiety level revealed that strategies and support were effective in reducing anxiety among women with breast cancer undergoing chemotherapy. And the intervention also found there is a reduction of 1.94% in depression among intervention group, but increased for about 1.30% in control group. And this showed that nurses play an important role to provide psychological support during treatment. And not only that, nurses' role also to educate and provide counseling to motivate patients to follow the treatment. And this may contribute to positive outcomes of chemotherapy and improve patients' adherence to chemotherapy. So for the research objective number 2 on the cancer treatment survey, or for the cancer related treatment concern. So a two-way repeated measures ANOVA analysis was applied to assess whether there were groups and time difference in cancer treatment related concern. So in sensory psychological concern and procedural concern, there were significant main effects for group, time and interaction between groups and time. And this suggested that the change of a sensory psychological concern and procedural concern among patients in both groups were significantly different across the time. And this study involved a long-term intervention has been shown to reduce sensory psychological concern among women with breast cancer throughout the treatment, with a difference of 6.2% between intervention group and control group. And this study also found that the intervention showed a reduction on procedural concern among women with breast cancer throughout the treatment, with a difference of 15.9% between intervention group and control group. And this finding suggests that providing information pertinent to cancer treatment is crucial, and with the use of reliable and valid instruments. And finding also shown that information which is tailored to patients likely to result in improved psychosocial outcomes and better recall of information. So for my research objective number 3 on the effect of intervention among overall quality of life, a repeated measure ANCOVA was applied to assess whether there were groups and time difference in patients' quality of life. In overall quality of life, there was significant main effects for group and time. However, no significant effects on the interaction between time and group was found. And this indicated that the change in overall quality of life patients for both groups were not significantly different across the time. So in regards to quality of life, no significant main intervention effects were found between respondents in the intervention group and control group, which warrant further discussion. So the lack of improvement in intervention could be related to the fact that change in quality of life might be difficult and might due to the duration of the intervention. Therefore, future studies should engage in interventions of longer duration and monitor the long-term effects of quality on quality of life. So for my research objective number 4 on the effect of intervention on this patient activation level. So a two-way repeated measures ANOVA analysis was applied to assess for patient activation level in both groups. So in patient activation level, there were significant main effects for group time and interaction between group and time. And this indicated that the change in activation level among patients of both groups were significantly different across the time. And this study actually involved with a long-term intervention that has been shown to increase the patient's activation level in the intervention group by 5.1% at the end of the treatment, but showed a reduction by 5.6% in control group at the end of treatment. And the finding suggested that those respondents with higher activation score in intervention group were more likely to perform self-care management behaviors and use self-care strategies as suggested and compliant with the chemotherapy until completed. And the effect of tailoring intervention also has encouraged patients to socialize, and also sharing information may help patients to increase skills and confidence. Okay, for research objective number 5 is the summary of the symptom burden between the group. So this table summarizes the results of symptom burden for frequency, severity, and distress between the group. And the results are shown that symptom frequency in both groups were almost equally the same in percentage. But however, in symptom severity and distress, control group has the highest mean rank for physical and psychological symptoms across the time. And for the summary of symptom burden within the group, so this table summarizes the symptom burden for frequency, severity, and burden within the group. And results shown that control group has more significant changes in symptom for frequency, severity, and distress as compared to intervention group. And these findings actually demonstrated that individually tailored self-care education using motivational interviewing significantly decreases some of the symptoms experienced, severity, and distress in patients starting from the first cycle until 6th cycle of chemotherapy. And the symptoms were such nausea, vomiting, dry mouth, stomach bloated, headache or giddiness, feeling agitated, and body ache. So the improvement of overall symptom burden suggests that enhanced self-efficacy beliefs and provides motivation lead to better self-management and consequently better symptom relief. So for the research objective number 6 on the self-care strategies implemented by the intervention group. So the figures show the self-care strategies used by women with breast cancer across the 3 cycles of chemotherapy. So among all the self-care strategies used at cycle 1, 3 and 5, sleep and rest, exercise, body image and eating habits were among the commonest self-care strategies used by the intervention group throughout the treatment. And this indicated that these self-care strategies were the commonest used to reduce symptom burden among women with breast cancer during treatment. So in this finding also showed that tailored self-care education intervention using motivation interviewing has improved on the utilization of self-care strategies among patients in the intervention group. And using self-care diary has helped patients in the intervention group to plan and implement self-care strategies throughout the 6 cycles of chemotherapy. So concerning the side effects of the chemotherapy as reported by patients, it was found in the present study that symptom burden was decreased in percentage and mean rank compared to control group. And from the findings also can be concluded that the more symptom patients had experienced, it will increase the utilization of self-care strategies in their daily life. So in evaluating the program, the intervention program, this table presents the details on mean score of patients' responses for each question concerning about the self-care education intervention program. And there were positive feedback obtained by them in each question asked, whereby the mean score was shown above 4. So for the strength and limitation in this study, the current study conducted among women with breast cancer undergoing adjuvant chemotherapy has strengths that should be highlighted. First, the phase 3 study used a large sample size, and data collection was conducted in one of the major cancer institute in Central West Peninsular Malaysia over a period of 15 months. And participants represented different socioeconomic backgrounds, education levels, and age group. And in addition, the study also used a well-developed instruments. So for the another strength is the homogeneity of the participants. So the participant undergoing chemotherapy for the first time in the intervention and control groups were similar in characteristic, and no statistically significant differences were found. And this provided confidence for comparison of the two groups. In addition, socio-demographic variables were included as covariates in the analysis were appropriate. And the other strength is the higher retention rates in the intervention group and control group, which are the 97% in both groups respectively. And these rates are satisfactory for maintaining the reliability of the study. So, and then the final strength is that the study used a mixed method research design, which included both qualitative and quantitative data. Although there was a lack of randomization in the quasi-experimental design, data were collected from two groups, the intervention and control groups. And this design is relatively strong since the difference between the two groups could be determined before the intervention. And if significant differences existed, they could be controlled statistically. Teams and sub-teams derived from the qualitative data could support and strengthen the content of the phase 3 quantitative intervention study in relation to patients' experience of symptoms and self-care practices during chemotherapy. And for the limitation of the study, so for the first limitation of the study is limited generalizability, and this study was conducted at the Cancer Institute in the public hospital located in West Peninsular Malaysia. Therefore, the patient who visit the Cancer Institute chosen for the study might not adequately represent the population of all Malaysian breast cancer patients. And for the second limitations relate to the fact that the phase 3 did not include randomization to the intervention because of concerns about the contamination between the intervention and control arm, which might have arisen in the case of randomized control trial. So although there were no statistically significant difference in baseline characteristic measure, the lack of randomization means that the intervention and control groups may have differed in unmeasured attributes that might have impacted on the outcome measured. So however, action was taken to reduce the selection bias by determining the inclusion and the exclusion criteria to make the sample homogeneous. So in addition, it realized that the self-report questionnaire also could lead to introduce bias to the result of the study, as it might not describe the true condition of the participant. because they might rate higher or lower that from the true condition. So, however, using self-reported questionnaire in the study provides a basis for psychological distress, quality of life, treatment-related concern, patient activation level, symptom burden, and self-care practices among cancer patients, as there was no information about them previously. So for the implications and recommendations, the results of study provide sustainable strategy for the provision of self-management support intervention within the oncology settings, and also asserts that self-management intervention not only require information provision but also psychological support and interaction structured to equip patients with skill and confidence to actively engage in multiple behaviors and managing their symptoms. So this finding also proposed that collaborating with multidisciplinary team on effective management of the multidimensional complex of symptom cluster with psychological distress is crucial. So in my conclusion, self-care education intervention program is an effective intervention to overcome psychological distress, improve patients' activation level, and treatment related concern. So the novelty of this study is that this is the first longitudinal study that measures the effectiveness of the self-care education intervention program on psychological distress, quality of life, treatment-related concern, patients' activation level, and symptom burden throughout the active treatment. So, however, longitudinal study after treatment completed is strongly recommended in future to examine the long effect of self-management support on quality of life, symptom burden, patient activation level, treatment-related concern, and psychological distress. So, before I conclude, I would like to acknowledge my supervisors, Prof. Dr. Khatijah Lim Abdullah. She's already retired and now in Sunway University. Professor Dr. Nur Zuraida Zainal from Department of Psychological Medicine, and Professor Dr. Wan Ling from Department of Social Science, Preventive Medicine. And also to all the breast cancer patient and staff of Oncology Daycare, Department of Oncology Clinical, and also National Cancer Institute Putrajaya. And also this study was supported by the grant from University Malaya under the which name as BKP. So this is my referencing. Okay, with that I will say thank you for listening to my presentation.
Yeah. Thank you, Madam Aziyan, for the informative sharing. Yeah. So we have one question from the floor. It is coming from Dr. Chan Heng Cheng. So Dr. Chan was asking, what are the weaknesses of your research, and how many candidates do you study?
Okay, you mean the weakness? Weakness of my study.
Limitations.
The limitations as what I have presented just now.
What would you recommend to improve? Let's say if a person would like to replicate your study, what would you recommend to improve?
Yeah, I think in the future I would like it to involve all the multidisciplinary team to be involved in this study, because as you know that patients have a lot of physical and psychological problems. So sometimes we need collaborative from other multidisciplinary such as dietitian, physiotherapists, and then of course, the oncologists, to provide extra counseling or extra advice to the patients while on treatment. I mean, throughout the treatment journey. Because to be honest, I mean, the nurses also, you know, they have a lot of things to do beside that, providing the education. You know, there are too many patients. So by collaborating with other multidisciplinary team, I think would enhance the patient satisfaction during the treatment.
Just to recap, how many candidates do you have in your study?
I have 246. 123 is for the control group, and another 123 for the intervention group. So altogether is 246 women with breast cancer undergoing adjuvant chemotherapy.
Oh, that's a good sample size there. So one more question regarding about intervention. Fertility intervention is important. So what are your measures to ensure that?
Yeah, in terms of fidelity, usually I will come out with the procedure, the manual for the intervention, so that it is actually been uh, for me to to ensure that I have delivered all my interventions accurately and adequately to the patients. And then because of I'm doing it alone, as this is part of my PhD study, so I have to ensure that whatever content that I've delivered to the patient is strongly apa being delivered lah to the patients. Did I ask your question?
Thank you. Thank you. Okay, ladies and gentlemen, now is already, I guess it's 9:05. So we are coming to the end. On behalf of the organizer, we would like to thank you for joining us in this session. We shall meet again in the next session of Breakfast at UM Health. So stay safe. Goodbye. Thank you.
Okay.